All right. Good afternoon, everyone. We have 12 o'clock, and my name is Dan Carey. I'm the chief. I was used to my last job. I'm the chief medical officer for the physician enterprise here at Providence, and great to join the core of moderators for Providence Grand Rounds. So today's topic is caring for pregnancy during the COVID-19 pandemic, lessons learned. A couple of things on logistics for the program. Many of you are regulars and some of you are new to Grand Rounds. All attendees are muted in this environment. Please use the Q&A box to ask questions and share comments throughout the presentation. The presentation is being recorded and will be posted on the Caregiver Grand Rounds site. And you will also find previous Grand Rounds there. Those who want, and I certainly want my continuing education credit for CME for our physicians, there is the portal at Swedish Medical Center. We have the number there, 225-453 for this activity, and that will be posted in the chat for our nurses and pharmacists. There will be a link as well to make sure that we get credit for this great educational opportunity today. Next slide. Consistent with our highest standard for unbiased continuing education, there are no conflicts of interest with our speaker today. And again, what are the learning objectives that our speaker has provided, that faculty have provided? At the end of the session, we hope that everyone will be able to first describe the impact of COVID-19 on pregnant patients, to articulate the stages of the COVID-19 epidemic and how these impacted the care and response in women's healthcare. Third, review the challenges and solutions in performing screening and visitation policies in mothers and infants. And lastly, identify the next steps for women's healthcare in transitioning to the endemic phase of COVID-19. Next slide. I would like to introduce our speaker, and he will do his own reflection. Dr. David Lagrew is a maternal fetal medicine specialist and physician informaticist with a special interest in maternal quality improvement. He currently serves as medical director of Women's and Children's Services for Providence St. Joseph Health in Southern California, and as a Providence System Provider Informaticist in Obstetrics. He holds triple board certification in Obstetrics and Gynecology, Maternal Fetal Medicine, and Clinical Informatics. In addition to these administrative and leadership roles, he continues to active in authoring numerous peer-reviewed publications and book chapters. He is a clinical professor in the Department of Obstetrics and Gynecology at UC Irvine, and he is the immediate past chair of the Society of Maternal Fetal Medicine's Clinical Informatics Committee. We are just so pleased and fortunate to have Dr. David Lagrew to speak with us today. Dr. Lagrew.
Hey, thanks, Dan. I presume you can hear me okay?
Yes, sure can.
Great to hear it. Well, thank you. And thank you for letting us share some of the lessons that we've learned along this journey over the last couple of years, not only for our region and our women's and children's, but in a system role as well. These are things that have impacted everyone, and obviously women and children's has been greatly affected. My reflections are always short and sweet. And one of my favorite people to quote is Winston Churchill, who said, when the facts change, I change my mind. What do you do, sir? And Mr. Churchill said this when he reverse course on some legislation in the parliament, and someone challenged him as waffling. But I think today, one of the biggest things that we've learned as we've gone through the pandemic is the fact that we have to be willing to change our mind. We have to be able to go with the new facts and the new recommendations. So I think that's a big lesson. Next slide, please. So let's look at some of those things and go through them. Next slide. This is what we'll be talking about today. I'm going to talk about COVID in pregnancy and what the general recommendations and outcomes are, the importance of communication, of following standards, of taking advantage of us as women's caregivers with our patients to improve outcomes. And then just some summary thoughts on sort of reflecting on the journey and what lies ahead. And then, of course, I'll be happy to answer your questions and answers. Next slide. So one thing that we most importantly have learned is that pregnancy is a high-risk condition. The CDC specifically lists pregnancy as that. And there's been numerous studies now to back this up. Of course, when we started the pandemic, we weren't quite sure as to how it would occur. But we now know that pregnant women have a threefold risk of ICU admission, threefold risk of invasive ventilation, 2.5-fold risk of requiring ECMO, and a 70% increased risk of death over non-pregnant controls. And it's unfortunately, as we'll see in some of the data, particularly true for moms who are older and moms of Latina and African American descent. Next slide. These facts and figures are now beginning to be borne out in some of the outcomes data. These data that were just released a couple weeks ago from the CDC, looking at maternal mortality statistics in 2020, showed that 861 women died of maternal causes in the United States, compared to 754 in 2019. This 20% increase, of course, is a really big deal for us. And we suspect much of it has to do with COVID. And as more analysis of maternal mortality comes out and these cases are studied, it's likely we'll see this. And unfortunately, what most experts predict is that 2021 will be even worse because the initial 2020 figures really were based on just a geographical area of the East Coast. Next slide. Now, if we take a look at the breakdown by race and by maternal age, you see that the problems that I alluded to for our Latina pregnancies, as well as those of non-Hispanic Black women. You can see that their increases in maternal mortality were significantly higher than the non-Hispanic white. And similarly, if we look at by age groupings as to where the really significant jump up in maternal mortality occurred, it was in the over 40-year-old pregnancies. And again, just like COVID outside of pregnancy, age plays a significant role and risk factor. Next slide. Now, one of the most important lessons that we've learned through all this is that communication is critical. Next slide. To deal with this, we've done a number of things. Early on, we built a regional Clinical Institute SharePoint page where we could quickly pass along information and recommendations and guidelines as well as pass along slide sets and recordings of updates. This paralleled some of the work at the system level, but really focused on what we were doing within the region. Next slide. And during the pandemic, in the early stages, we actually had twice weekly updates. They were scheduled for 1 hour, but many of them went 1 to 2 hours. And most of our ministries and providers joined these. They typically had somewhere between 40 to 140 participants throughout the regions that were on there. And as of last Friday on the 4th, we had held 137 of these updates since the beginning of the pandemic. So a lot of time, a lot of effort was put into this. Next slide, please. So we started off each and every one with looking at the data. The data were very important. We had multiple sources from Johns Hopkins, the New York Times, the California Data Center, the IHME site for predictions, a number of different sites that allowed us to show our caregivers, show them where we've been, where we were, allowed us to predict as to what was going to be coming in the near and over the next few months. And we also, by studying these numbers, of course, learned that cadence of the positivity goes up. Then we would see the case numbers go up. A couple of weeks would go by and we would begin to see the hospitalizations go up. And then we would see, unfortunately, 2 to 3 weeks later, the death rates rise. And that allowed us to very closely understand where we were going to be throughout the pandemic. And I think while the numbers obviously were quite concerning at many times as each of the surges, as the original, as the Delta, as Omicron hit, it really allowed us to to understand where everyone was. And this was particularly important. Next slide. Then we would have numerous news articles. We found that the Johns Hopkins site had a really nice library of updates. We would mix in with their various news and papers that had come out and put this all together so that we really and truthfully were passing along the latest information to our caregivers. Next slide. Then, of course, we regularly checked the CDC, our major organizations like ACOG, AAP, others, the Society of Maternal Fetal Medicine, the State Department of Health, et cetera. And we would then share and put these into format and allow folks to have a library for themselves of the latest recommendations. Next slide. And then what we tried to do at the regional level was then distill these down into something that folks could then use as sort of this is what we're going to follow here. We used a lot of the tools that we had made on the system level, as well as on the regional level, to pass these down so that in Southern California, we had, at the time, we had 10 delivery services. So having a synchronized approach to what we were doing was very helpful. And then, of course, we would always alter these. We would have discussions, things like, what are you doing for visitors? How are we doing with screening before they came in? What do you do with the baby when it's the mom is positive, et cetera. So it really was a nice way to set best practice standards throughout the region. Next slide. And of course, like I say, there was regulatory issues that came up, and when they came out, especially the state guidelines, we would be able to immediately get these down and review these with everyone and adjust what we were doing. So, for example, this example on the screen is the visitors policy, which obviously from different stages of the pandemic changed on almost a daily, so it seemed like daily, definitely every few weeks. Next slide. Then one of the other important things in each of these presentations is we reminded people about two important things. One is, what was the toll that was being taken on our patients? And we actually responded to that. We worked with the system and got a good deal of the information, not only about COVID and what was going on there, but as well as part of our maternal mental health program, things about depression, things that patients can do. And then we routinely strove to have each and every patient who was discharged make sure that she had the Circle app on her phone and was instructed on how to use that. And then we mirrored that with setting up hotlines within the region for patients to call when they were having symptoms. And just as everybody else saw, the number of patients and calls and things of that nature was vastly increased during the pandemic. Next slide. But at the same time, we also took a moment to remind people that all of this, the fear in the initial stages of the pandemic, the fatigue that's happened over the last few months, these have taken a toll. And it's no secret, I think, to anybody in medicine that they understand that the extra effort this has taken, the worry about their own families and themselves and things of that nature, has really taken a toll. So we would routinely remind them of the resources that we had here within Providence so that they could reach out and encourage them to help themselves, help their colleagues get through this. Next slide. Now, another big lesson was following standards saves lives. And I can think of nothing in medicine, or at least in my career, that I've had to deal with where the standards and the recommendations change so rapidly. But to really get the benefit of the latest studies, of the latest understandings, things like what's the safety of vaccines, what's the best antiviral, what can we use in pregnancy, et cetera. All of these were just a continuous, ongoing onslaught of what we had to deal with. Next slide. And so here are some of the big ones. Encouraging vaccination of children, and that, remember, most pregnant women have young children in their family. So while we are Women's and Children's Institute and want to do it for the children themselves, the other important thing is making sure the family gets vaccinated. Working with our community population. So, for example, here in Orange County, we did a couple of seminars with the staff at an organization called Moms Orange County that routinely go out and help families through pregnancy. So by educating and working with our community resources, this allowed us to reach out further than just our own patients. When it was appropriate, when it came along, we helped implement postpartum vaccination. In fact, one of the lessons learned was that when the initial discharge protocols for vaccination were put in, they had left out pregnancy because of the fear over what could happen. In other words, the concerns over safety. Well, it turns out, obviously, these were pretty safe, and obviously it's a different conversation, which we'll talk about in a minute, but we have to include them. So we very rapidly worked on the informatics side and the pharmacy side to get postpartum vaccination going. And then, of course, we worked with our provider groups and our independent providers to try to get them to vaccinate as many folks as they could do. And then lastly, drugs like monoclonal antibody usage in pregnancy, what were the differences in indications, things of that nature. And more recently, I would say the antivirals like protocols for Paxlovid and others. These types of things were discussed. Next slide. We would put these together into recommendations. I would say over the past few months, that where the things such as visitation policies, screening policies, things of that nature have stabilized. We haven't had to update as much. This has mainly been updated on what types of therapies and what were the changing recommendations. Things like understanding that the monoclonal antibodies that seem to be effective against Delta, but did not be as effective for Omicron. These types of things we would pass along and put in our recommendations. Next slide. We are very fortunate, I think, in women's health. ACOG and the Society of Maternal Fetal Medicine did an excellent job of putting out numerous publications and best practice. This one, for example, was on, it came out very early on outpatient assessment and management for pregnant women. As you can imagine, when things started, people were scared as to what's that going to do for our pregnancy. And so we really had to partner with our emergency departments, our urgent cares, our provider offices, and work out the schema as to who's going to get checked, who's going to stay at home, et cetera. And so, as I mentioned, these organizations gave us a very good outline of how to follow that. Next slide. The other things I would credit the Society of Maternal Fetal Medicine and others on is very detailed analysis of things like vaccination. They would put out publications with all the latest data and studies and things of that nature. They had national experts that were then going over these and then coming up with recommendations. So as this slide, which is from a time period and when we were trying to pick, hey, which vaccine should we give our pregnant patients? Are the RNA vaccines safe? What about J&J? Et cetera? Those types of questions, we simply followed the national guidelines. Next slide. And as I mentioned, we would then work to embed these guidelines into tools. So this, for example, is some screenshots that were implemented in August of last year, putting in the vaccination recommendations with all the specifics on what we were to do in postpartum patients. Next slide. And then we would also follow other what I would call non-pregnant guidelines, and then, of course, try to filter through those Again, the type on this is a bit small, so I apologize. I'm trying to read that, but this was a very nice document that came out, and then we would filter these as to what was appropriate in pregnancy, what wasn't. And I think it's a general statement. Really and truthfully, it was because these patients are at so much increased risk. The biggest mistake that we saw was the fact that people tended to undertreat or delay therapy or wait a second, I don't want to hurt the baby. I don't want to do things of that nature. And so the fact of the matter was most of the therapies, such as the monoclonal antibodies, most of now the antivirals are pretty safe throughout most of pregnancy. There's some nuances, but nonetheless, the bottom line is these folks are at higher risk and require intervention. Next slide. Testing was a big deal. Testing for us was something that allowed us to test the mother upon admission to labor and delivery, not only so we could screen her and, of course, put the proper precautions for infection, et cetera, and visitation. But remember, in our case, we have two patients, the mother and the baby. It turns out of COVID positive mothers, about 1 in 20 of the babies will actually be COVID positive themselves, which is good news because that's not a terrible number, certainly compared to a lot of the other viral diseases and things of that nature that we see in pregnant mothers. But still, it's something that we had to be aware of, and we had to have the proper management of the baby as well. Next slide. One of the other big things that hit us, though, is that when you screen that many people that are asymptomatic, you do pick up the so-called prolonged positive PCRs. And what I mean by that is we would see numerous women that were positive or had a verified COVID infection 2-3 months earlier and then show up on labor and delivery. Now, we learn to obviously space out where we can, but we saw an awful lot of persistent positive PCRs. And I think, and I've said this numerous times now over the past few months, this is an area where not only outside of pregnancy, we need more better testing schemes and understandings, but particularly in pregnancy, because it would be extremely helpful for us to know if we could pull antibodies and look at IgM and look at IgG and figure out where we are in the infection. That would be very not only good for how our moms are going to do, but projecting how what's the risk of the baby. Next slide. And again, we followed the standard testing recommendations and things of that nature and management schemes that were put out by the CDC. Obviously, these changed and we changed. And of course, one of the other lessons, which I think we all learned, but in particularly in pregnancy, is the different strains seem to behave differently. And obviously, Omicron was much more infectious, but fortunately less serious. So again, trying to understand in the midst of a surge, the delay between what to expect from this particular variant of concern was a real issue for us as well. Next slide. So I would say if you forget everything I tell you today, I really would like to get this across, and that is that the management of sick COVID patients, and I would say probably stretch that to getting sick patients, it requires extreme extreme teamwork. We try in our domain to really use teams of caregivers, OBs supported by OB hospitalists, OBs supported by maternal fetal medicine, and our non-women's caregivers like the intensivists and the infectious disease specialists. This is just one thing that has to be done in the care of these patients to maximize. We do not have the expertise in general in women's and children's to be able to care for a mother who's going to be sick, who's going to be intubated, who goes on ECMO, et cetera. But the flip side is also true. Helping our infectious disease folks understand the normal physiologic changes in laboratory values, in cutoffs. So, for example, the recommendation of what the PO2 that requires therapy is different in pregnant women. We have to raise that level because, again, we're as you remember, we're breathing for two, right? So we have to worry about the baby as well. So again, there's certain nuances where we bring expertise to the table, and this is just for the best outcomes. It really takes a village with these patients. Next slide. The other important thing that I would like to stress is the importance of we as women's healthcare providers taking advantage of our special relationship. We really have a bond, particularly during pregnancy, with our patients. And this I don't only mean doctors, I mean midwives, I mean nurses, I mean all of us. They really depend on our care and our expertise. And so taking advantage of that has been more important than ever, I think, in the COVID epidemic. Next slide. So as I mentioned, one of the things we did was utilize the new tools. Remember, most every mother, regardless of economic status, carries a cell phone. And so we realized in our domain, if we give them a stack of patients, a stack of papers or things of that nature as they walk out of the clinic or walk out of the hospital, most of them will just throw them away. And so by taking advantage of the Circle app and embedding our content and our recommendations and things of that nature in that's been a big win for us. So again, encouraging them to use these new tools is something we really emphasized. Next slide. Now, the other big thing to talk about, of course, is vaccination. No population probably had more hesitancy than the pregnant population, for the very reason that anytime we do anything to someone in pregnancy, their first response is this going to hurt my baby? Is this going to, I'm not worried about myself, but I'm worried about what's the long-term effect of the baby. And I think, as most probably know on the presentation, there were a few patients who got pregnant in the early vaccine studies, but they weren't supposed to be pregnant, and they were excluded, as typically happens with pharmacologic studies. They were excluded. So the amount of data we had was less, and the unknown was greater. And so it really put us in a bind, because here we have one of the highest risk populations to care for, and yet we have the least amount of data that could be there. So how did we manage this? Well, first of all, you can see this was really the course. You can see early on when the vaccines became available, we just didn't get the uptick, and we were way behind other adult populations. Now, some of it was that pregnant patients are a bit younger, and those populations did not have the uptake that you saw in the elderly populations, where the risk was widely known by the general public. But in point of fact, we were delayed when we compared to our own segment. This graph is nice. It shows you we're up to about 60% of moms now. It also shows that the light blue part of the bar is vaccinated prior to pregnancy, and you can see the real key now is that folks are coming in with being vaccinated in pregnancy. And hopefully this, as we get the data, will show, I think part of what happened in the Omicron surge, we saw less sick mothers, and part of it was, of course, Omicron, and part of it was the vaccination numbers. Next slide. Now, as I mentioned, one of the big hesitancies of the mother is that she wouldn't want to get vaccinated because of what it might do to her baby. Well, the flip side of that is that when data like this paper that just came out in the last few weeks, and there's been a few before this, but this is a really nice study that showed how many babies came out with, in other words, got protection from the vaccine in pregnancy. And the women who had been vaccinated, those infants had a lot less chance for them to have problems. So again, as statistics like this came out, it allows us to tell mothers, hey, not only are you taking this for yourself and the increased risk, but you're helping your baby. So it takes away one of the big hesitancies in pregnancy. Next slide. Now, I think it's important when we're counseling, and this is one of the slides that we use to counsel patients in stepping them through comparing what her risk factors are. So again, I'm not going to go through the whole slide, but we did explain the increased risk to her, explain how this was different than influenza, explain what the disease did to pregnant women, et cetera. Remind her of the risk of long COVID, remind her of the antibodies going across to the baby and offering protection to the baby. So again, pregnant women require special counseling. Next slide. The other thing, of course, that we have learned, and this we knew about this, but it became very, very critical during the pandemic, is how we cancel our patients. And we understood also the importance of women. Women are the chief medical officers of the family, and they typically make the healthcare decisions for most of the family. So the other importance of focusing on counseling women was the fact that we were really focusing on families as well. So very important. The other thing is modern women are so much more informed that it really, really has to become a shared decision-making process. We really need to engage the patient, work with them, answer their questions, get them the materials they need to make an informed decision. And then the other thing, of course, and again, going back to our statistics I shared with you earlier, particularly critical in our communities of women of color that we do this work, because these are the highest risk individuals. And these really, in a sense of health equity, these are people that we really have to focus on. Next slide. We would share with them the data. This, of course, is the New England Journal article on the original vaccination symptoms and efficacy studies. So we would actually, we wouldn't use this particular slide, but we would distill this down into them, warning them about, hey, by the way, your second injection, you're going to have more symptoms, et cetera. Next slide. And again, we would go back over the risk and benefits, the prevention of maternal morbidity and mortality, the reduced risk of in utero infection and newborn infections, and how that passed along. And again, it was an argument that, particularly now, I think that we have so many more safety and pregnancy for the vaccination data. It really, really allows us to make a convincing argument to our patients that this is the right thing to do. Next slide. And of course, we again followed the recognized recommendations, this from the ACIP, from the CDC, and again, used this to our advantage. Next slide. Fortunately, in women's healthcare, we were also lucky in that most every major society, governmental group, things of that nature aligned themselves with these recommendations. We would call them out. So, for example, certain times, this I pulled this slide from where I think it was one of the particular vaccines. The Public Health England had said, wait a second, let's be careful with this. But in general, I would tell you, certainly from an American standpoint, we were pretty aligned in all our recommendations. So things like the American Society of Reproductive Medicine weighed in on could this cause infertility or things of that nature? And they made very clear statements that this was not the case and that these vaccination was safe. Next slide. Now, when you counsel people, you have to address valid concerns. So things like, hey, we can't tell you long-term effects, but these, with our experience in other vaccines in pregnancy, we feel pretty comfortable with that and things of that nature. And this slide now actually is somewhat dated because we filled in. So we do have data on children, et cetera, but at the time we didn't when we started our campaign. Again, I think you have to, shared decision-making requires honest and open data. Next slide. And then, of course, a good deal of counseling is dispelling invalid concerns. So does an mRNA vaccine alter DNA? Does it speed up? Was the sped up development? Did they skip any steps or things of that nature? Herd immunity is better. And of course, the classic one was, were there microchips in the vaccine? All of these, we scripted answers for our caregivers to give. And I think the one that actually isn't on this particular slide that I mentioned a moment ago about infertility and long-term risk, that was particularly important in women. Next slide. So it's been a journey. Next slide. This is a screen print from the other day. The good news is, if we look at the United States today, obviously most of us have come out of the Omicron surge and are in pretty good shape, particularly for us in the Providence system, and these rhythmic surges have taken their toll on us, as I mentioned, and we have had to respond a little bit differently and things of that nature. I would tell you that most all of us are clearly ready for a few months of without a surge. And as we have cautioned folks, take a breather, help yourself, restore yourself, but at the same time, begin to prepare and make sure that we're ready just in case. So the protocols that we put into place that we may back off on, we're gonna be ready to turn those right back on. Stocking up PPE, all the things that the rest of our ministries and our clinics and things of that nature are going to do. And then the other thing I would say, when you look at it from a journey aspect, is we want to keep on top of this, understanding the latest information, being prepared so that when we do need to aggressively go out there, we can. Next slide. Now, the other thing about the journey, there are times, especially between surges, that we put in a little bit of breather for folks. I think this is one of the slides I used last summer when the counts were really low, but we're starting to go back up. And my sister, who's a pediatrician and kind of a smart aleck like myself, I guess, sent me this one to stay home unless you wanted to be intubated by a gynecologist. And while it seems kind of funny now, in the midst of certainly January 2021, there were a number of our OBGYNs and even myself that were preparing to go into the non-COVID wards, the non-obstetrical wards, since we were doing relatively better than the others to help out. And, for many, that's a scary thing. Next slide. But I want to end on a serious note, and that is that we also look back at the journey and remember the fallen. And for those of you who've never seen this particular graphic that's made up of, unfortunately, pictures of caregivers and providers who passed away during the last couple of years. It's really a sobering thing. And again, it reminds us that we're all worn out, we're all tired, and that we're going to have to stay on our toes. So, Dan, with that, next slide. With that, I'm happy to answer a couple questions if they're out there. And
sure thing. Just excellent talk, David. Really appreciate the comprehensiveness. And here I was ready for a question. I'm an adult cardiologist who over the years sadly had to take care of many women with peripartum cardiomyopathy, less frequent. Beta blockade has really made a huge difference over time. But Dr. Ted, I believe it's Dr. Ted Berdumi, who's, I believe, in anesthesiology at Santa Rosa, California, asked what was the incidence of myocarditis among vaccinated women as well as their offspring versus the unvaccinated. So we're able to detect the benefit in reduced myocarditis, not cardiomyopathy, but myocarditis or pericarditis or cardiomyopathy for that matter, in those either with vaccination or with the disease itself.
It's interesting, Dan. I can't answer that for women right now because I think we're still waiting from this latest surge. As I showed you the graph, the problem was, of course, that we didn't have enough women vaccinated to really answer that question back in the early parts of 2021. So I think those data will begin to come out. Clearly, to your point, and I think I made it earlier, we saw a lot less sick people in the Omicron surge. and almost no one that was vaccinated, much like others. Now, I do know the data it's pretty clear now, as you know, that's coming out in teenagers and things of that nature, which we did pass along because, again, we're women's and children's, that if you look, there clearly is a risk of myocarditis post-vaccination. But it's virtually, I'm shooting from the hip a little, but I want to say there's a 10-fold increased risk in the children that got COVID and went on. They were the ones you really had to worry about, especially the severe cases. But as to, again, what recently has happened, were we protected because Omicron wasn't as bad, or was it truly an effect of the vaccine? I think we're still waiting on maternal data for that.
Right. Thank you. And I think if you do, I know Omicron, is it because so many are vaccinated, or so many may have had Delta or Alpha along the way,
right?
Or because it was inherently less toxic is part of the question, but likely a little bit of all of that. But yeah. I do remember just that issue of if this 1 in 500,000 type of risk compared to if you do get it, even in a 20 to 35-year-old group, there's 10-fold or even 100-fold difference of critical illness if you were to get it. So I think that proportionality is important to discuss. Do we have any other questions? Feel free to type it in the Q&A. And I will also just reinforce in my last role in public health, getting the healthcare workforce, especially women during their fertile years, vaccinated was a huge challenge. And one of the reasons our hospitals had much lower utilization of their initial waves of supply of the vaccine as we distributed it to public health centers, but also a lot to acute care. So those in category 1A would get vaccinated first and protect themselves. And I know that is a communication challenge. And again, we have a lot more facts in 2022 than we had in early 2021.
Yeah, and I would say back in the spring of 21, when the vaccines were just getting available for pregnant women and things of that nature, we really had to do a lot of coaching with our nurses and a number of our providers about if they had declined the vaccine, how they then changed their counseling to patients to make sure that they made that, a very personal thing, but still passed along the correct information. And I think it's very hard. Obviously, we have a lot of pregnant, docs and nurses, right? So, I think it's, I'm kind of glad we're past that stage because that was actually pretty tricky.
Thank you. And there's another question in the chat about, has Omicron already induced herd immunity? I know, David, that may not be your area of expertise.
No.
But if you'd venture, I have my own thoughts, but
I'll throw it in. I think I guess I'm giving up on what's really herd immunity. I guess I've gotten beaten down where I'm not so hopeful. I do think every projection that I've seen is we're going to have several months of not having another surge, and that it would likely be unlikely, given the diversity of Omicron and things of that nature, that another one would hit. And hopefully by then, or at least the way we look at it is, hopefully by then the newer vaccines that are better at immunizing against all of the different variants are out. But again, unfortunately, I don't think we know that. Again, I think enough people did get hit and do have enough between the combination of vaccine and natural immunity that our chances of a big surge that'll overwhelm us is unlikely, but it's not going away. And remember, most of the planet is not vaccinated,
Right.
and so it's a problem.
Yeah, I think you're right. I'm not an infectious disease specialist, but a lot of work in public health the last 4 years, and any of our folks can type in an answer if they have some particular expertise. But I like you think that the experts that I follow, very unlikely to see the kind of at least hospital utilization that we've seen because of the uptake of less so on boosting. We could get a lot better in this country and in many states and in the Providence area around primary vaccination, pretty good. Boosting, not so much. And also a lot of both likely asymptomatic as well as symptomatic Omicron, but on the heels of Delta and previous. So, but again, a new variant that does not have the cross-reactivity is always a concern, although less of a concern. And as you stated earlier, vigilance is definitely the order of the day, even as we move towards some recovery and normalization as we go forward in the months ahead.
Yeah, and I'm going to get in trouble from my son and my daughter-in-law who both went to the Naval Academy. But, this is one area I say go Army, beat Navy, and get their vaccine going. I'll be happy to see that thing.
Right. All right. Well, I think any additional questions before we end today's grand rounds? I don't see any. Again, there's a reminder on your screen about receiving CME credit. I will do that myself. I need my continuing education credits, as many of us do, or those that are licensed, and really appreciate this program. Dr. Lagrew, thank you so much for just a world-class review of an important topic, and really appreciate your willingness to share your experience and knowledge with us today.
My pleasure.
Thank you. Everyone have a great afternoon.
Okay, bye.